So this is following NHS England guidance about the setup of hot and cold sites. You can also have a mixed model within each CCG so that you may have a mixture of hot sites and hot and cold zones within each particular practice. Now, one of the most important things that we have try to emphasize, is that a face-to-face appointment with a patient is the last resort. If you have a suspected COVID patient, that this is the very last thing that you would want to try to do. And if you can do anything remotely or by phone, then that is the preferred option. If you are going to see a suspected COVID patient, then you have to make sure that your staff are protected by PPE, and also that you can segregate patients that are suspected COVID from non-COVID patients that may be attending your surgery at the time. One of the most common questions that we are asked is, how do we assess patients with suspected COVID on a remote basis? Now, this is really, really difficult in certain ways. I mean, the diagnosis of COVID is actually reasonably simple, because we're talking about patients who have fever, who have malaise and fatigue and muscle aches, and with a new cough. We also know that perhaps that the presence of anosmia and the presence of gastrointestinal symptoms may also be symptoms of COVID. But what we're really interested in is trying to assess the severity of the patients. And the most patients that are the ones that are the most severe are going to have the pneumonia and have the respiratory symptoms. So we are we're much more interested in how their respiratory function is at the time. So screening for severity of illness, there are a variety of questions, and these are all based on the Oxford CEBM questions. So it's asking about how their breathing is today. Are they more, you should be able to observe whether they're so breathless that they cannot complete sentences. That is probably one of the most sensitive ways of detecting how severe a patient is. And this is similar to what's been, you may have heard about the ROF score that's been touted around on the internet and on various websites. The ROF score basically is actually measuring whether or not you can complete a sentence or not in one breath. So our age-old what we've learned in the past about observing whether patients can complete sentences probably still holds, and is probably as accurate as a ROF score. The other important thing to notice is whether or not the patient has changed over the course of days. So increasing breathlessness over the course of a day or two will be an important sign to notice that their patient is deteriorating. And these are the sort of patients that you would want to measure oximetry on, pulse oximetry. We now know that patients can exist in the community who have what we call comfortable hypoxia or silent hypoxia, who can become very severely hypoxic without much in the way of symptoms. They are not as breathless as you would imagine. And sitting there at rest, you may not observe them to be very breathless, but in actual fact that if you actually count their respiratory rate, or if there's some way of counting their respiratory rate, you may find that they're actually raised into the 20s. So that is a useful sign to try and detect if you are doing a remote video conferencing with them. And if you're observing them in your practice, then that may be also very useful. Oximetry is one of the most important ways of actually detecting hypoxia. Now, obviously, if you're doing a video consultation or you're seeing them face-to-face, you may be able to observe cyanosis, but that's a sign that probably we've all forgotten how to do or what to look for. But cyanosis may be a very important sign if you haven't got oximetry in the patient's house. There have been quite novel ways of actually detecting, of doing oximetry. So you can either bring them to your hot site or hot zone. You can bring them to the car park of your hot site or hot zone and stick an oximeter through the car door window for them to do. There are, in Hammersmith and Fulham, I do believe that they are using medical students to cycle oximeters to patients' houses, post them through the letterbox, and then you do a remote phone call with the patient to measure their oximetry whilst they're at home, and that if they are poor, then you act on the poor result. But if they are borderline, you may leave the oximeter with them so they can monitor from day to day, and it's a form of safety netting. In this guidance, we do have, in the next iteration of this, a statement to say, so this is the second iteration. The third iteration should be published on Tuesday next week. And that will actually talk about silent hypoxia or patients who become hypoxic without obvious breathlessness, and how you can detect that with oximetry. So moving on to the next page, after the assessment, got it wrong, after the assessment, then this is the way that we categorize patients into category 1, 2, and 3. This is based on NHS 111, and this is exactly the same way as they would actually assess patients on the phone. So category 1 is patients with severe symptoms that need either emergency admission to hospital, or if they have an advanced care plan in place, then these are patients that you may want to actually manage at home or do a telephone assessment with. The moderate symptoms who are in category 2, again, you may want to do a telephone consultation. These are the patients that you may want to bring to a hot site or a hot zone in order to assess them more formally, because these are the ones that are in the more nebulous category, where you need to do their oximetry in order to make a clinical decision about how you manage them. Category 3 are the patients with mild symptoms who can probably be managed at home, but there is a slight proviso, and in the next iteration of this document, the proviso is that if they have serious or significant comorbidities, even though they have mild symptoms, you may want to monitor these patients a bit more closely, because they're the ones that are likely to do badly if they progress to more severe COVID problems in the near future. So even though they have mild symptoms, if they have significant comorbidity, you may want to take these patients, you may want to actually monitor these patients a bit more closely. And what we mean by monitoring is actually by making a register of these patients and giving them a phone call every 24 hours or so. And if you have access to pulse oximetry, to actually get them to measure their pulse oximetry every 12 to 24 hours as well. You have to remember also that some patients already have a pulse oximeter, and some patients may actually have pulse oximetry available on their smart device, like an Apple Watch, and there are some apps on your iPhone which purport to measure your pulse oximetry as well. So, use any means possible perhaps to get an idea of what their pulse oximetry is. So again, this is the following page is about a reiteration of saying that a face-to-face consultation is actually the last resort. And if you are going to do a home visit, we recommend that you actually discuss this with a colleague or a peer, so that you actually get two people's opinion about whether or not a visit is necessary. And you have to ask yourself the question as what extra information will actually a visit actually give you before you actually go ahead and do one. Okay, and it's useful to actually document why you are actually going to do a visit. Please remember that when you are visiting a patient, if they have suspected COVID symptoms, then you should be wearing PPE. But you have to remember that if you're visiting a patient that is shielding, or a patient that is at risk of severe disease if they contract COVID, that you are going to protect the patient from you potentially having COVID as well. So wearing PPE actually protects the patient from getting COVID rather than you getting COVID as well. So there's a two-way process here as well. If you are seeing a patient that's in category 2, pathway 2 is talking about the particular patients in category 2. And within this category, there are what concerns that we are missing patients that have other diseases or other conditions that may lead to similar symptoms that COVID would have. And we have to remember that just because COVID is around, that all the other problems are also still there. So just be wary that there are alternative diagnoses to COVID that you need to rule out, as well as COVID itself. If you are suspecting COVID because the patient has a pyrexia and a cough and other COVID-like symptoms, then we can risk assess them into 3 different categories. So these are the category 2A and 2B patients who are subdivided into low, medium, and high risk according to their physiological parameters. So the physiological parameters are laid out, as you can see on the screen there, using the saturations, the heart rate, and the respiratory rate. Now, somehow you're going to be able to have to assess this either by a face-to-face consultation or remotely. And as I said, one of the most useful things is actually by getting a pulse oximeter to them in some way or another. So anybody that's got a pulse oximetry that is less than 93% should be seen in hospital for assessment. Now, they may not be admitted, but or they may be observed for a few hours before they are sent back home again. But I think that trying to manage a patient according to NICE guidance, apparently NICE guidance says that you do not need to worry too much about severity unless their saturations are below 92%. If they're below 92%, we would be very concerned. Yeah, so that's why we have a slightly higher pulse oximetry for admission, and this is in sort of alignment with what the EDs are currently doing. So EDs are admitting or observing anybody with pulse oximetry of 94% or less. So we would consider high risk anybody with saturations of 93% or less. A moderate risk or medium risk is 94 to 95% with a heart rate of 90 to 110, and low risk is above 95%. And then medium risk patients, you could consider a trial of treatment at home and try and prevent secondary bacteria. But you really do need to monitor these patients quite closely, and we would recommend monitoring them by daily phone calls and trying to provide them with some means of measuring their pulse oximetry on a 24, 48, on a twice daily basis, perhaps. And make sure that they have either access to you or make sure that they have safety netting phone number to call if they are deteriorating. So that's just an explanation of what we just said. Oops, sorry, I've just gone down the wrong slide. So that's so the page following this is how you would manage a patient with pre-existing comorbidities, respiratory comorbidities, and also with COVID symptoms as well. Now, there's been a lot of concern about the use of inhaled steroids and the use of oral steroids in patients with COVID. In patients with asthma and in patients with COPD. We are advocating that patients with asthma should continue with their current asthma therapy unchanged. Now, there has been a huge run on asthma inhalers, on all respiratory inhalers. Patients are suddenly deciding that they will be compliant. There has been a 400% increase in the demand for respiratory inhalers in the last few weeks. We would plead with you not to overprescribe or not to give prescriptions for respiratory inhalers in excess of what your normal supply would be. So please do not give advanced prescriptions for 2 or 3 or 4 months over than what they used to have, because it is really stressing out the supply chain for respiratory inhalers. But patients should be encouraged to take their normal medications, whether they have asthma or COPD. In an acute exacerbation, in the absence of COVID symptoms, patients with asthma should, if they're having a very severe exacerbation, should take an oral steroid course as per their asthma management plan. They should not be denied oral steroids because in asthma, oral steroids can be life-saving for them. So they should not be advised not to take their oral steroids. With COPD, it's a slightly different matter because in COPD, the oral steroid course is not necessarily life-saving. What steroids do with COPD is that they may reduce the duration of symptoms at that time. So it's not something that is going to make a huge difference to what's going on. So we would say that with patients with COPD, if they have COVID symptoms such as a new cough, which is different from their normal cough, in conjunction with pyrexia, in conjunction with muscle aches and anosmia, then they could probably be managed without oral steroids and just take antibiotics if they have purulent sputum and increase their inhaled bronchodilator using a spacer. However, if they do not have COVID symptoms and they have a known steroid responsiveness, i.e. they've responded to oral steroids in the past, they have a past history of possible asthma, or they have a past history or going through your blood tests of having an eosinophilia greater than 0.3, then you may want to, then you should consider giving them a course of oral steroids at that time. So that's the general management of patients with coexisting respiratory disease. One of the interesting things, though, that we have noticed is that in China and in current day terms, patients, although patients with COPD, if they are admitted with COVID, do worse than patients without COPD, the number of patients being admitted with asthma and COPD is a lot less than you would expect from the prevalence in the community. So something in that we are doing with asthmatics and with COPD patients, dare I say, seem to be protecting them from actually contracting COVID. So it may be their inhaled steroids. It's very difficult to say. It's just the speculation that that's a possibility that something is going on. So, you know, that's a really good reason to encourage patients to continue with their current treatments. There is one proviso about this, and that is that patients with COPD that are on very high dose of inhaled steroids, i.e. patients that are taking more than the equivalent of 1,600 micrograms of beclomethasone a day or more, and that means that Seretide 250 Evohaler or Seretide 500 Accuhaler, these patients may be more at risk of community-acquired pneumonia. So therefore, it's difficult to know whether or not they are at risk of COVID pneumonia. This may be an opportunity not to stop their inhaled steroids, but perhaps to reduce them back down to a more sensible dose of inhaled steroids, which is about 800 micrograms a day of beclomethasone equivalent. Because patients with COPD already have underlying lung disease, their oxygen saturation range may be slightly relaxed depending upon what their baseline saturations are. So if you do have an idea of their baseline saturations, their criteria for admission or criteria for separation into the mild, moderate, or severe category is dependent upon their baseline saturation. So we give a rough guide of what saturations that you should be looking for before you refer to a hot hub or refer to A&E. One of the most important things as well is that if you do have patients with severe COPD, is to consider what their ceiling of care would be and perhaps discuss with them what their ceiling of care, what they would like their ceiling of care to be, because making advanced care plans is extremely important and really helpful in the long run in order to manage expectations. We give a little bit of guidance of what to do when you are faced to doing a home visit or a face-to-face consultation. Obviously, you know, if you are dealing with a suspected COVID patient, then you should be wearing PPE. Only do a home visit if there is no other option, as we have said. You should minimize the patient contact at all. Do you really need to listen to the chest? Do you really need to perform spirometry, peak flow, CMR, or any other sort of thing? You know, really, at this current time, these things are not really necessary. You don't need to take sputum samples. You shouldn't need to collect viral swabs. The most important things, as we said, are monitoring, looking at the respiratory rate, looking at the pulse oximetry, and looking at the heart rate along with the pulse oximetry. Do a blood pressure if you're concerned about sepsis and hypertension as well. But if you can get away with it, then you don't need to. Again, advanced care planning. If you do advanced care plans, please put them on CMC, on Coordinate My Care, because A&E departments and LAS can Access Coordinate My Care, so that we would be able to know what the advanced care plans are. Okay, following that section, then we have a brief section on PPE. There has been a lot of discussion in the press because it seems that PHE sometimes seems to be changing their minds about what is required. But we give what the PHE current guidance is there. You have to be aware that these things may change. So we are updating the this resource pack every week. So the current one for next week will be out by Tuesday morning, hopefully. And then we should be having new iterations every week. This is version 2. We've already looked for and started the alterations for version 3, which will be out Tuesday next week. Looking at the PPE, there are a few areas there which we just need to clarify. One of them is around nebulizers. Now, there is a lot of debate whether nebulizers are currently an aerosol generating procedure or not. According to the World Health Organization and some international asthma guidelines, nebulization is an aerosol generating procedure. But according to RPHE, it is not an aerosol generating procedure, and therefore you do not need full PPE to be in the same room as somebody with COVID that is having a nebulizer. There is still a lot of debate going on, so you may see this change in due course. But we would say that if you do need to give high-dose bronchodilators to a patient and you're in the room, then this can be done more safely via a large volume spacer like the Volumatic, and giving 8 to 10 puffs of salbutamol through a large volume spacer. This is probably just as efficient as a nebulizer. If you have to give a nebulizer, I mean, you shouldn't need to do it in an emergency setting with a suspected COVID patient, but nebulizers, if they already have one at home and they have COVID symptoms, then they should do this in a well-ventilated room by themselves without anybody else there, so to avoid aerosolization exposure to anybody else in the household. We would not really advocate the sort of giving patients currently now, new patients a nebulizer because of this. And as I said, you can recommend instead giving high doses or multiple doses of salbutamol via a larger volume spacer. The next section is cardiopulmonary resuscitation. Now, I do realize that a lot of you may have received the guidance sent out recently saying that you should not start cardiopulmonary resuscitation because there is, including chest compressions, because there is a risk of aerosolization during chest compressions. That is the advice given to you via your STP or CCG. This is also the advice from the Resuscitation Council UK. However, this is at odds with the advice from Public Health England, who currently state that chest compressions are not a aerosol generating procedure, and that it is safe to do chest compressions. But if you're worried, you can put a cloth or something over the patient's mouth whilst you're doing chest compressions. Mouth to mouth is not recommended, and nobody should intubate or do any airway work, including bag mask resuscitation, unless they are equipped with proper PPE. So this is in debate at the moment, and unfortunately, there isn't firm guidance on this because the two major advisory panels are at odds about this, but hopefully they will come to some agreement in the near future. But keep your eyes peeled, and we will keep you informed as to what the what the final decision is. When we are talking about treatment in specific settings, this is about treatment of respiratory disease in the home or in care homes or in the community. So again, we reiterate how important it is to establish advanced care plans with your patients and get them discussed. It seems that a lot of patients actually are quite sanguine about their chances, and some of them will prefer to be managed at home, regardless of whether or not they are, if you are aware that they may not be suitable for resuscitation or for ventilation if they are admitted to hospital, then some patients are actually quite happy to be managed at home. So it's very important, I think, to establish this and make an advanced care plan for them. There is a lot of information that we give there because we know that this isn't something perhaps that people have been doing very much of in a primary care setting at all. But we have reduced quite a lot of information there about advanced care planning, Coordinate My Care, and also the ethics behind it as well. So we've published, we put in there they should be there somewhere. Oh yes, there is at the bottom there about advanced care planning. But I do think that later on we have the ethical guidance around advanced care as well. The next section is talking about, again, what treatments that you can give at home for chest infections, for wheeze, and rather than using a nebulizer, how you can use large doses of salbutamol through a spacer. We are talking about, I think the section above that, we just missed off, there is a bit about antibiotics. Yes, sorry. Just at the bottom of that bit, there's a bit about antibiotics for the prevention of secondary pneumonia. For patients in category 2A that you're treating at home, you may want to consider preventing secondary pneumonia, and the antibiotic of choice in that setting is doxycycline, and amoxicillin is the secondary choice currently. But we don't recommend the use of the standard in the past community-acquired pneumonia, a combination of amoxicillin and erythromycin. So doxycycline is the first choice, amoxicillin is the second choice, both for 5 days. We've talked about the steroids already. Oxygen is another thorny issue that we will talk about a bit more in a minute, because there is a separate section on the prescribing of oxygen, and I know that it's a question that many of you have been wanting advice over. The next section is talking about discharge. We have a more full section on how we safety net and monitor patients at home in the next iteration that's going to be published on Tuesday. So at the moment, what we are saying is that if you are sending a patient home from a hot zone or a hot hub, you need to make adequate provisions for continuing monitoring of the patient somehow. So making a register of these patients and actually arranging to ring them every 24, 48 hours, and having some ways of being able to access oximetry in these patients. And also we'll be giving a guide on what questions were the best questions to ask in order to detect deteriorating respiratory function in these patients. Some of you will be already looking after patients who have been discharged from hospital, and the care of these patients who will be maybe being discharged hypoxic from hospital. Some of them will be followed up by the hospital team for a few days, and once they're stable, their follow-up may revert back to yourselves or to a hot site, depending upon local circumstances. We will be giving a bit more further information about post-discharge arrangements and what is the best way of monitoring these patients and what to look out for, some guidance about what to look out for in these patients once they are back in the community. Section 3 is about the use of oxygen, which is causing a lot of issues at the moment. In patients that are discharged from hospital, as we said, they may be discharged hypoxic, so they may have saturations of between 90 to 92% when they're discharged but they would have been stable for a couple of days before they were discharged, and that their general clinical state will be improving. Now, it seems that the natural history of these patients is that they continue to improve, and very few of them deteriorate following discharge. So they aren't of a huge concern to us, and they will not be discharged on oxygen therapy because we are expecting their trajectory of improvement to continue. So they should be out of hypoxia within a few days after discharge from hospital. So we're not really too concerned. Patients discharged from the emergency department are slightly more worrying because they have borderline saturations of 92 to 94% perhaps. And these patients hopefully will have some way of being monitored at home with pulse oximetry rather than giving them oxygen. We do have a cohort of patients that have chosen to be treated at home or in a nursing home who are hypoxic. These patients, therefore, would have already been deemed that their ceiling of care is not for ventilation. We should note that possible treatment as well could be non-invasive ventilation. So a lot of these patients can get non-invasive respiratory support in hospitals with a mode called CPAP, which can improve their oxygenation. So that is an option. But if they decide that they would prefer to stay at home, then there is a consideration for home oxygen for palliation of symptoms. Now, most palliative care documents will say that oxygen is not a treatment for breathlessness. It is a treatment for hypoxia. So if you are both hypoxic and breathless, it is not unreasonable to give a trial of oxygen therapy to see whether or not that relieves breathlessness. But the mainstay of breathlessness alleviation is the guidance given through the palliative care guidelines, some of which are in this document a bit later on. So actually giving things like opiates, giving things like benzodiazepines, using the non-pharmacological treatments, managing anxiety, managing expectations, and all these things may be as effective as using oxygen therapy. What we have observed in many of the COVID patients is that they have silent hypoxia. So even though they are profoundly hypoxic, and we're talking about saturations of 80% perhaps, they are not necessarily that breathless. So oxygen may not actually be useful or be beneficial, and that if they are for palliation, you may not need to give oxygen therapy for them, because we are not expecting them to recover, and we are just there to perhaps maintain the comfort of these patients at that time. If you are, I mean, if you are thinking that they may benefit with oxygen because they may recover, then you can prescribe oxygen on a HOOF-B form for them in the community without going through your home oxygen service. Although using your home oxygen service may be beneficial as well, because it will keep them on a list. So if you have got a local home oxygen service, and I am aware that Ealing does not have a home oxygen service, but some of you may be able to access one, and that is the place to go to, perhaps for more advice about oxygen therapy. Section 4 is a big section on palliative care, and a lot of these patients that are elderly and frail, hospital is really not the place for them, because if they are admitted to hospital with COVID, they are going to be, they're not going to get the same sort of attention that they would get in their nursing home or care home. Patients, are not allowed relatives in until the last final moments. So, they will be in a very foreign setting, a very unfamiliar setting, and they may be left, unfortunately, alone for periods of time, and they may be dying alone in the hospital ward. So this is really perhaps not the best place. Hospital is really not the best place for them. So please consider how we can manage or how we can maintain these patients in a home setting. But obviously, we have to judge every patient by themselves and with their family, but their families need to be aware that if they are admitted to hospital, they may not be able to see their loved ones. So the guidelines go through, as we said, the non-pharmacological management of breathlessness, and then also the pharmacological management as well of both breathlessness and anxiety. So it gives you a range of treatments that you can use in these settings. Getting towards the end, I'm pleased to say. So this is again just a reiteration of how we can manage their breathlessness. Finally, we have the business as usual, because we have to remember that patients without COVID still need our care. So this is just reinforcing some of the elements of respiratory care. Don't forget that this is a respiratory document. This isn't about diabetes or heart disease. This is about patients with respiratory disease and long-term condition as a long-term condition. And it's just a little bit of advice there about how we maintain business as usual for these respiratory patients. We know that we can't conduct pulmonary rehabilitation at the moment because of the social distancing rules. A lot of these patients will be provided with home care packs to advise them about what exercise they can do at home, but also some of them, some of the pulmonary rehab outlets that we have been trying to do pulmonary rehabilitation virtually. So they may have Zoom classes where they will get patients to Zoom in and do pulmonary rehabilitation over the internet. They will be given access to exercise videos and YouTube videos about how to maintain activity at home. This is a really important thing. So if your patients are isolating or shielding at home, it is really important to encourage to maintain their mobility and exercise capacity, even though they're not allowed to go out. We also have singing for breathing at home. We know that singing for breathing is one of the most popular classes that we have for patients with COPD or chronic lung disease. And we have been conducting singing for breathing via Zoom as well. Finally, we just again mentioned about the high-dose inhaled steroids, and that patients who are on high-dose inhaled steroids are at risk of increased risk of community-acquired pneumonia. So therefore, if you are in a practice that's a cold site and you're not having many patients turning up because they're all too scared to come to a GP surgery at last, then you may want to just go through your patients list and do a search for high-dose inhaled steroids and see whether or not these patients, we give a lot of the guidance in the appendix of the document to tell you, to help you, guide you through how you can identify patients who may be suitable for a reduction in inhaled steroid dose and how you can actually do it. We have a lot of appendices to help you through. So we have the standard appendix about those patients that are at increased risk that you have seen in the shielding letter. We have the basis of the questions on breathlessness according to the Oxford CE evidence-based service. Appendix 3 is about other lung conditions other than COPD and asthma that you may be confronted with, such as interstitial lung disease, sleep apnea and bronchiectasis, and how to manage those during these current times. We have the frailty score, because the frailty score will help to inform you about whether or not a patient is likely to be suitable for invasive ventilation or not. And currently the cutoff point for suitability for ventilation seems to be somebody that is at the CFS scale of 6 or more. So 5 is a bit dodgy, but 4, 3, 2, 1 is obviously okay at the moment. Things may change if we have a further surge of activity, but at the moment, patients who are CFS 6 would be deemed not suitable for ventilation. So it's not just about age, it's not about the number of long-term conditions you have, it's mainly going to be based on frailty, which is why we've included this, and so that this aids your discussions with patients about their advanced care planning. We have, this is the bit section about how telling you, suggesting about how you can identify patients that may be suitable for reduction of inhaled steroids. It tells you which ones are high dosages, and we have a separate section for asthma patients and for COPD patients, and how you can step these patients down from their dosages. We have another section on how to put patients onto CMC. That's quite a long one, I'm afraid. And then finally, I think that we have a leaflet on patients that have decided that they would like to be managed at home, and about how to manage their breathlessness symptoms when they are at home themselves. I think that's about it. Yeah.
Thank
Good.
you very much. Thanks, Vince. That was really helpful in pulling things together. We've got a series of questions, and I've bucketed them into various themes. Sarah, did you want to come in at this point?
Yes, can we put up the slides that I did that address some of the questions, and while we do, we'll start doing that. I think they were really good questions, everyone, and they're things that we've heard this week a lot on the support line. So I thought what we'd do, if Cameron can put up the slides, I'll go through what the common themes have been this week, and then I'd like to say that probably most weeks now we'll run a mini webinar and go through the lessons we've learned together and from one another during this time. It's hard, and just to stress again that things are changing very rapidly. We're seeing different things and learning about how these patients behave with COVID all the time. So I think what I'm trying to say is there's often not a right or wrong answer, and going back to clinical acumen and how we feel is important. So if we can go down to the next slide, and if questions can come in while we're doing this. So one of the common things is symptoms have been persisting for several weeks. I've been phoned by quite a few general practitioners who say, you know, we've had patients that have had symptoms for over 2 months. They've been unwell intermittently. And then more history will come out that they may have had a secondary cause. So the main purpose of this slide is to really be clear that if symptoms go on for too long, yes, it may be COVID if they're coughing and they're on the mend, i.e. they're coughing a bit less every day, their fevers are abating, etc. But if they have persistent intermittent fevers and there's something else going on, they may have a secondary bacterial pneumonia. We've seen these. We've seen a community-acquired pneumonia that's been missed, so they haven't had antibiotics, and so they've been going on with their bacterial pneumonia and not. So we said always consider secondary causes or another cause if symptoms persist. Next slide, please. I can't go down. So yeah, so we said if you're concerned, then bring them to the hot site just to check out, or do a video call just to make sure we're not missing. Second thing is pleuritic chest pain. So pleuritic chest pain, that is not just the intermittent, oh, you know, I've got a bit of chest pain. We see the intermittent, oh, I'm getting chest discomfort quite a lot in COVID recovery, actually. It's an odd, nondescript sign, but people say, you know, I'm much more aware of chest discomfort, but it's not pleuritic. It doesn't cause pain on breathing in. They're not jumping, and it's unusual. So we would always say if someone has definite pleuritic chest pain, they need to be investigated further. We haven't seen pleural effusions. Vince and I were talking about that earlier. I really haven't seen it in the hospital, and speaking to my colleagues, it's not common. They may have a secondary pneumonia that's therefore causing them to have pleurisy, or they may have a PE. And so I would always say that these patients are the ones that do need to be looked at again, and to make sure there's no other red flags. Next slide. Cameron, so I can't do it on my screen for some reason.
Cameron, you need to flip the slide. Yeah.
Yeah, so the next query is people phone about high-risk patients. And actually the general review from me, Vince, and the others have been that these generally need to be referred to medical assessment. So oncology patients going through chemo, have become tachypneic with hypotension, you send them in. They're high risk and they need to be reviewed. They could have sepsis linked to their chemo. It could be something completely different. We've also had patients that have come out of hospital that have begun to desaturate again, have developed jaundice. Well, of course, you send them back. Don't feel bad about getting these patients re-reviewed. That's what the hospital is there for. Again, hypertension, diabetes, tachypneic, hypoxic febrile, you shouldn't, your risk assessment needs to be that they do need to be assessed. And absolutely, and I agree with your comment, I don't think hospitals should be refusing to help out in those situations and to give some safety netting. Vince and I are very happy to take support line queries if you're not sure whether this patient should come into the hospital or be assessed. But any doubt, oncology goes in, recently discharges that's getting worse again should go in, and if they're getting very hypoxic, SATs 88 or below with COVID, definitely need to go to hospital. As Vince said, 92% is low. Next slide. So the other one is clinically well. Good, they're clinically well. They don't need to worry about those ones. So they're well, they're getting better, but they might have had an incidental imaging done. And we've seen this twice. We've had someone that's gone in for a CT for another reason. By the way, hospitals have stopped doing routine CTs now, but there's been a few that have had routine CTs and there's been changes on them that might have been COVID. If that patient is well, there is nothing you need to do. They might well have had some viral change on their CT, but if they're fine and they're recovering, that's not a problem. And on that time, we advise the GP just to assess on the phone to make sure the patient has remained stable. Next slide. Oh, this is a big one. It's coming around a lot, and there will be some more guidance on this coming out, as Dr. Mack said. So GP practice acquiring pulse oximetries. What do we do? How do we monitor? Next slide, please.
So, Sarah, can I say on this that NHS Digital has acquired 220,000 oximeters, and we're in the process of seeing how we distribute that across CCGs. But this is well recognized. Yeah, thank you.
Absolutely. So I think
the problem is that it's only 30 oximeters per practice in the UK.
Yeah, I think that is correct, but I think we're assuming that we can reuse them. I think we're going to have to find a mechanism how we risk stratify patients and how we use it most appropriately. And we'll probably...
Mahini and I have been talking about this and making absolutely sure there'll be an operational policy behind them, and that's things. But the key message is at the moment, that is that if patients with COVID and have breathless symptoms who have SATs 94 or below or fall into a high-risk category, that's important. They should get medical assessment in the hot zone or video conferences and potentially assessment in hospital. If they don't need to come to hospital and you want to keep them monitored carefully, they're the ones you should give an oximeter to. So we believe it is helpful in risk stratifying symptomatic breathless patients in a community setting, but it needs to be attached to a clear pathway. And the most important thing is that you need to have clear pathways in place about what you do, i.e. if someone's young, fit, and definitely would be intubated, they are ones you need to concentrate on. But likewise, if someone is frailer and you would want to know whether they would go into a hospice or have more support at home, or actually would need to come to hospital for oxygen because they wouldn't manage, there's also a reason to do it. But always be clear at the beginning of trying to monitor someone with an oximeter what your end point will be if things got worse. So we're currently drawing them up, and I'm sure they'll be available for next week as an iteration. And Mahini and I know these need to be drawn up for North West London, and we'd value anyone's input into what we feel will be useful. So at the moment, it's those 2A patients that you feel actually we do need to watch them. We need to look at them every day, and we need to know what the pattern of the oxygenation is. A question came through earlier, I don't know whether Vince wants to comment too, about how sensitive these oximeters are. Variable is the answer, but if you've got a trend, then it's helpful. But see it getting worse, it's helpful.
If they're CE certified, and most of them usually are CE certified, they are accurate within plus or minus 1%.
1%.
And Sarah, I think we can also say that
ups are terrible. So Jay, I can see you've written the mobile app data isn't very good, actually, so they're not as sensitive as the ones that says.
I wouldn't use the iPhone one at all. But the Apple Watch one is not so bad, but it's not good in lower settings. So it's not validated in saturations below 94, 95%. So it's fine for 98, 99%, but not for anything lower than that. So, you know, although we say use it if there's nothing else available, it's not something that I would rely on. And also, it doesn't give a good signal if you are moving or if you are septic. And
so not
can we also say that not everybody who is hypoxic needs ventilation? You know, we've got a lot of people who are on CPAP or non-invasive ventilation with high flow oxygen who are managed quite well in the hospital. So not everybody needs a ventilator.
I think that's right. I think not everyone does. And you know, Vince and I were talking about this earlier again, in that, you know, there is a proportion of people that come in hypoxic that will need to have CPAP or will need intubation, but they're in the right place if they do.
Yeah.
So, you know, if they've got risk factors, having them in hospital means that should they need intubation or CPAP, they're in the right place to deliver it fast. Back to the oximetry. So best not to suggest there are phones at the moment. In reality, they're not good at the lower levels, as we said. But in that 2A group, when you just feel uncomfortable, you think, actually, I'm not comfortable, this patient's getting better. But do have a plan on when you'll call them, and that should be the next day, definitely. And with an app that we're looking at in Northwest London, that might be 8-hourly or 12-hourly as a monitor, just for the future. Next slide. Hello?
Yeah.
So home oxygen. So staying on the theme, we've had lots of queries about home oxygen. So, you know, what are the guidelines for home oxygen arrangements for COVID patients and those that have palliative care needs but don't want to go to hospital? So the guide at the moment is very much alongside the palliative care guide generally. So you can have a trial for symptomatic relief of breathlessness with oxygen, and it may help. It again depends on the frailty level of the patient. And our experience is if someone is dying from COVID or dying from something else, the drugs such as opiates and midazolam often help more. And this has definitely been the case with people, the frail elderly that get COVID. And actually oxygen in care homes has been proven to be more, it's just been a hindrance. They get very agitated in care homes. Most of their presentation is with delirium and confusion rather than hypoxia gradually coming on, and their disease progresses very fast. But our main point here is to adhere to local palliative care pathways when it comes to that, and don't automatically go to oxygen as a relief. So we haven't been recommending, I can just see you've asked about care homes with high flow. We haven't been recommending that, Alex, no. Next slide, please. Pediatrics, so multiple calls, and I've put a slide right at the end about this. The support line is for adults, but today I had a chat to the pediatric team, and I've got the numbers for you for pediatric questions. And again, if you do come through to the support line in the future, we'll give you the numbers to go. But Vince and I aren't pediatricians, so we wouldn't be able to give you advice as regards governance.
So I think we're quite clear, Sarah, on that. Across Northwest London, the pediatricians have come together and we've circulated pediatric hotlines for all the trusts facing the CCGs.
Yes.
So that should be there for people.
Wonderful, wonderful. And once we come to the end, you'll see I've put all their phone numbers in as well, Mahini, so that should help. Next slide, please. So these are for community, so not so relevant to Ealing, but it's just saying if you're in a boroughs or Hillingdon, we will still, next slide, we will still see patients on virtual imaging. And again, we did say right in the beginning, Mahini, if there is a real need or a concern about a respiratory patient you have in Ealing, of course we will help. So again, we can come through to the support line. Whilst it's set up for hot sites, if you have queries about other respiratory issues and you can't get them seen in a hospital, please do come and ask us, and we're there to support you. Next slide. So contacts, you've got these, the hot site numbers there. The respiratory advice .imperial is also helpful if you don't need a quick reply. We'll probably get back to you within 48 to 72 hours at the moment on that advice line. And the last slide, I believe, is the paediatric one, and then we can take some questions from you. So we can leave that paediatric numbers there, or we can rotate them around, Mohini. We can send them around.
These have been shared. Sarah, thanks, Vince. I had a couple of questions which I have bucketed together. One was around the issue of use of ACE and ARB inhibitors in people. So in primary care, we are now seeing patients in their second week who have been COVID suspect, and we are reviewing them quite regularly. So what do we do with them with dehydration if they are on ACE or ARBs and diuretics? Should we be changing their antihypertensive? So that was one question.
Can I answer that?
Yeah.
I've been keeping an eye on this in the medical press quite a bit. The guidance from the hypertension societies and the cardiovascular ones worldwide is saying that you should not stop them because the AR2Bs in particular theoretically could be protective against COVID infection. And although hypertension may predispose you to problems, in actual fact, the risk factor is cardiovascular disease in general, and in particular heart failure, not just hypertension, although many more patients do have hypertension, but don't forget that many elderly patients have hypertension. So, you know, that's something that goes hand in hand with being elderly, is having hypertension. So it's not necessarily, it's better that the hypertension is controlled than mucking around with their ACE inhibitors and AR2Bs at the moment.
Okay, the second question, I've had another question about saying people in week 2, because in primary care, we are seeing people in week 2, and I've asked Tony Willis to start to say what the prevalence of that is. Is there a role for steroids in week 2 for people who are still breathless? That's a question that's come up.
Sarah?
Sarah's on mute.
Yeah, sorry, I'm here. I think at the moment there is no evidence for recommending steroids for COVID in primary care or secondary care, actually. We're just not doing it yet.
Thank you. The other question which has come up is around desaturation on exertion as opposed to being desaturation at rest. Any thoughts or comments on that?
So Sarah and I have had a chat about this already again today. Desaturation at rest is already a major clue. So if they are at 94 when the normal saturation should be 97 to 98, then I don't think you need to look for desaturation. If they are somebody that is being discharged, we may be using desaturation on discharge as a guide to whether or not they're fit for discharge. What might be useful in doing an exercise test remotely is actually determining how breathless the patient actually is. And yes, you know, they may desaturate, but the 40-step challenge, or getting them to walk up and down the stairs once and come back again and talk to you, maybe observing how breathless they are, maybe just as good as looking for desaturation on exertion.
Thank you. And I think we're getting a lot of questions because in primary care, certainly we are now into the second week of people with COVID suspect and following them up and seeing that some of them do well. I think we know that. I think, is there any advice apart from what we know, which is to use our clinical judgment with the guidelines on breathlessness when to send them in? Is there any specific guidelines on week 2?
So what we said earlier on was about pulse oximetry, and we think that the most it's interesting noise.
It's clapping.
Yeah.
NHS going on.
The most useful way is trying to get pulse oximetry to them somehow. There is no easy way to determine what their pulse oximetry is, because pulse oximetry is your most discerning or most the most accurate way. There is no other way that you can, because these patients have silent hypoxia, there is no other way really that we can determine clinically who is suitable. You know, we cannot see, we cannot tell who is hypoxic because a lot of them may look comfortable at rest.
I think sometimes there was a question earlier, Vince, about exertional symptoms, and I do think that one of the earlier signs can be that if you question them with those good questionnaires that Vince did in the beginning about, you know, are you more breathless when you're walking up the stairs? Are you more breathless when you're doing things? Do you feel unwell? That often is a pointer to them getting more hypoxic.
Thank you. Can I just, there's another question which has come up, which was, I know when we talked to the critical care consultants that there was an issue about thrombosis and alteration in people's thrombotic functions. Is there any advice to primary care in the second week with people who are on anticoagulants? And just a second question on that, alongside that, you could take abnormal liver function tests when people get discharged. Is this just an inflammatory response, as we will see in most people with a raised AST when they have an inflammatory, it will just settle down? Is there anything specific to COVID post-discharge?
I can talk to the thrombosis bit. In intensive care, and in post-mortems, there is a lot of microvascular thrombosis. And there are a few patients that have come in with disproportionate low saturations that have been found to have proper PEs in the absence of DVTs on CTPAs. And there is a thought now, a school of thought that says that your first investigation should be a CTPA rather than a chest X-ray in patients that are hypoxic. A lot of patients will have high D dimers on admission, and this may be an inflammatory response, or it may be a sign of microvascular thrombosis. But what is known is that patients with high D dimers do not do well. Prognostically is a bad prognostic indicator with high D dimers. So if you've got patients on anticoagulation in the community, ideally, you know, keep them on anticoagulation. And there is a debate currently around whether or not patients admitted for COVID with severe disease should be anticoagulated as a routine, because it seems that microvascular coagulation seems to be common, is more common than thought, and maybe explain why they have a high D dimer and why they have oxygenation, which is hard to correct. I'm not sure about the, what was the other question about?
Just something around liver function.
Liver function, I'm not sure about. Maybe Sarah can answer to that one.
Oh yeah, I'm just answering the one about going back to work. Right, so liver function, yeah, we are seeing deranged liver function in hospitals, and that does seem to be related to a high CK as well. So is it some sort of, again, linked to coagulopathy, linked to something else? We're not sure is the answer, and I don't want to say the wrong thing. I'll look up some data and talk to our hepatologists and let you know.
Sarah, could you just give the briefest of conversation update on where we are with the use of any new drugs? And we've said they need to be as part of a research trial as opposed to just being used ad hoc. And if you could just...
Yeah, so there's trials going on across northwest London looking at uses of HIV medication in the ITU situation. And there's also a trial called Recovery, which is looking at, again, antivirals within the more severe groups that come into hospital. I don't yet think there are any studies going into primary care, but there's lots of applications to look at things like hydroxychloroquine and also antibiotics such as Azithro. At the moment, we do not recommend them being given outside trial. Mm-hmm. As soon as they come live, we'll let you know. But, and I think that probably will be in the next week or two.
And I think people are saying it's quite clear we shouldn't be using them because that just conflicts
We 100% shouldn't be using, and in fact, Vince will know this too, there is some evidence in China that people that got given hydroxychloroquine at high doses, it was high, and azithro, that they actually develop liver problems.
Yeah. And I think
and dropped dead, by the way, because of long QT.
Oh yeah, then QT, yeah.
And actually, I think just a reminder to say that, you know, the world is not just COVID. There are people who will have non-COVID related respiratory problems. And now that we've done the 3 weeks of keeping people at home, those will now start to surface. And we need, as general practitioners, to be aware of that, and obviously make the appropriate, what we are in the process of doing along with Sarah and Vince, is to try.
I think that's a really useful point to say, Mohini. Most people that get COVID, 80% of the population has a mildish to moderate disease, and they will get over and they will get through this. And that's really important to remember. We're always seeing the tip of the iceberg and people who do very badly, but people do well, and we do get people off intensive care, and we do get people out of hospital. So we need to concentrate on
even old people.
Yeah, and even old people like us. And please remember that I really do have concerns about us being so COVID in our view that we do miss other things. So please always think about your clinical acumen and think, could this be something else that's been going on a while now? Are the symptoms typical? And
actually, this is well documented in children now.
Yes.
Children are presenting too late, and we have had instances of that. So that's a really important thing for us to consider. I think the other, we've talked about anticipatory care planning and the guidance on that. I think one of the issues is people with COVID dying alone at home.
It's just
it's a challenging one for all of us. And no easy answers on that one. There is also an update coming out on people with dementia who are going into delirium and the use of medication. This came to the London CAG, and there'll be some guidance coming out on that. Are there any other questions that I have missed from here, please? Angat, Alex?
I think, Mohini, you've got all of them that I sent. Did you get both emails, 2 emails that I sent through? I think Adam's got a question there.
Adam, did you have a question? Go for it.
Yeah, on page 22, the heading seems to be a bit confusing. It talks about COPD and then or smokers. I mean, are smokers meant to be socially isolating that for 12 weeks? I've not heard of that before.
Page 22. Sorry, who is controlling the screen? Can they go to page 22?
Cameron, is it you to go back to page 20?
I think Vince, it's still with you with regards to the document. You should be able to
control that. I don't seem to be able to control that for the moment.
Let's take it outside this room, Adam. We're reviewing, as Vince and Sarah said, these guidelines are going to be reviewed on a weekly basis. Let's pick that up as an action. Take it outside this room. We're already looking at version 3 of that. Let's pick up the issue that you mentioned around smoking. I picked it up, but I wasn't quite clear. Was there any other questions from anybody who feels who haven't been answered?
Mohini, you did get both. Did you get both the emails from me?
I did. I think I've bucketed the questions and answered and asked most of them.
Sorry, will be 20 minutes.
Sorry, who was that?
Sorry.
Okay. Sarah, Vince, is there anything else you wanted to say as a...
Can I just say, from some of the calls I've had from GPs, I think that you are all doing an amazing job out there, keeping people, managing people with fairly complex and severe disease out there. All credit to you.
Thank you. And I mean, can we all just jointly say it's a huge thanks to Sarah and Vince for their time. I think this was incredibly helpful, I think we've all learned a lot from it. As with everything, as we're learning more about this disease, this will iterate and this will change. I just wanted to thank you very much for your time and really, really appreciate it. Thank you.
Pleasure.
Thank you.
Thank you, Vince. Thank you, Sarah.
Thank you.